Good morning. What are reasons? Today we have a lecture from Dr. Sarfaraz Baig, is a senior laparoscopy and bariatric surgeon at View Clinic, and he is a digestive surgery clinic also. He is ex assistant professor at Calcutta Medical College, and is very much in bariatric surgery. So this lecture will help you answering your theory question in DNB paper. Dr. Baig will be giving a brief overview. Dr. Baig, I will read and start.
Right. Thank you, Magunda. Thank you. It's an honor to be here. And let me just skip this and play this. So can you see my screen and can you hear me? Can you see my screen and hear me?
Yeah, yes, both.
Okay. So I'll begin. So thank you very much. I bring greetings, and I will try to be as brief and relevant as possible. I know we are looking at DNB students for whom at some point of time, I think just about a decade back, this wasn't even a chapter in the surgical textbook. So now that it has become a chapter in the surgical textbook, it is important to see bariatric surgery from the point of an exam, which is either a long question or at least some short note or a viva question which can come. So, this is an overview of bariatric surgery. So when we say bariatric surgery, we are talking about the disease which is obesity. So first we need to learn about obesity, and then we can talk about bariatric surgery. So what is the definition of this disease which is obesity? Some time back, obesity was not even considered a disease. It has been a recent phenomenon. Therefore, it is important to know what the definition is. So if the body mass index, which is weight in kgs divided by height in meters square, if it is more than 30, it is obesity. But in the recent NIH guidelines, which is endorsed by the various bodies in the world, experts are included there. In Asian community, if the BMI is more than 25, that can also be defined as clinical obesity. Now, you can imagine how many of us will become defined as obesity if the BMI is more than 25. But we have to understand the reason why it has been dropped down. You see, in the Caucasians, if the BMI is more than 30, then it leads to diseases like diabetes, liver disease, so on and so forth, all the metabolic syndrome. But in Asians, when the BMI is more than 25, then the incidence of these diseases rises sharply, suggesting that we tend to acquire visceral adiposity more at the lower BMI. So a Caucasian at 25 may have BMI 25 may have about 15% body fat, whereas we might be having 25-30% body fat even at a low BMI. What are the obesity associated diseases? You know many of them already. You know diabetes, you know hypertension and dyslipidemia, right? Liver disease, you have to be aware of it. One tends to forget liver disease, but NAFLD, non-alcoholic fatty liver disease, then non-alcoholic steatohepatitis and cirrhosis are very important diseases only due to obesity. In India, the commonest cause of liver transplant is not hepatitis B or C anymore. It is obesity-induced cirrhosis. Very important. Also not mentioned in the GI list is gastroesophageal reflux disease. Again, one of the commonest cause of gastroesophageal reflux disease or GERD is obesity. Apart from that, what else is written here? Cancer risk. Yes, colon cancer, endometrial cancer, breast cancer. All these cancers are associated with obesity. So these are the same, having the same genetic predisposition. Mood disorders. A lot of our patients will have depression secondary to obesity. They are unhappy about their body weight. They have poor image about themselves, and they don't go out of their houses. And so there's a sizable number of people with obesity who are depressed. Heart disease. As you know, the commonest disease of cause of mortality is now cardiac. And if it is cardiac, then what is the commonest cause of the cardiac diseases? Again, obesity is one of the leading problems leading to heart attacks. And reproductive disorders. In our country, you may have seen mushrooming of fertility centers. And why is that? Because we're having a higher rise of polycystic ovary disease, endometriosis, so on and so forth. And many of these diseases are directly linked to obesity. So it's a huge disease. It's not obesity. It's called obesity and obesity associated or related diseases, OARD. Also, I think it is very important for all of us to note that the name, the nomenclature of obesity is changing. It is now recommended by various bodies, including the endocrinological societies, to call it adiposity-based chronic disease. The reasons are many. Obesity, first of all, social perception is of it is not a disease. Number two, it has a social taboo. Oh, you are responsible for your disease. Obesity is your problem. Whereas when we talk about tuberculosis, we talk about lung cancer, many of which can be, because of some habit, but that is not eliminated as a disease. But why is obesity eliminated as a disease in social perception? Therefore, the nomenclature is adiposity-based chronic disease, which means it is because of the cellular fat. Number two, it is leading to chronic disease. It's long term. It cannot be treated, it can be cured. Like, for example, diabetes. It can be cured. Once you have it, you have it. Like cirrhosis. So all these chronic disease. And lastly, the word disease means it is a disease. You cannot say it is just plumpiness. What is the cause of obesity? Very interesting. All of you are aware of this, right? The amount of calories I consume and the amount of calories I spend, the balance between the two decides whether I am going to have more fat in my body or not. That is how we think. This is, although a okay model, this is definitely not the correct model. The correct model is probably this. There is a set point hypothesis, which is now promulgated as a valid hypothesis, where we now realize that there is a set point in somewhere in our brain. Let's say my set point is 75 kilos. The body is going to keep me at 75 kilos no matter what. If I diet, if I run, if I exercise, the body has this tendency to keep it at 75. That's called homeostasis. Long term, allostasis. So the set point is fixed by the brain. Think about your heart rate. If your heart rate is 75, well, no matter what you do, how much you run, as soon as you stop, even if it went to 120, where will your heart rate be? 75. If you had a heart rate of 60 and you did running, exercising, whatever, but then you sat down, how much will your heart rate be? 60. That's homeostasis, similar with the body weight. The problem is when we think about obesity, we think about calorie excess and physical activity. No. See again, calorie excess is just one of the reasons. Gut hormones play a role when we eat. How much of gut hormones are produced? What gut hormones are produced? That decides your body weight. Adipokines, what are the fat cells releasing? What hormones? That is adipokines. Leptin, how much is released? That is going to decide our body weight. Neural, how much of sympathetic activity and parasympathetic activity is there in our body? That is going to decide our body weight. What kind of gut microbes I have in my gut? That is going to decide our body weight. Whether these fat cells are releasing any inflammatory cytokines, which are leading to chronic inflammation, is going to decide what kind of diseases I will have. Diabetes, sleep apnea, arthritis, chronic liver disease, all are diseases of chronic inflammation. Psychobehavioral problems, obviously, if I have a depression or I am a emotional eater, night eater, I have bulimia, all these are going to cause obesity. And finally, I wrote something in the bottom, genetics. And it's important to realize that I'll come to it in a bit. All the gut hormones, when you look at the gut hormones, that itself is a short note for us. But I don't want you to remember this. I just want you to remember a few gut hormones that has a bearing with obesity. GLP-1, PYY, GIP, ghrelin. At least these names you should keep in mind that these are gut hormones which have a bearing when we eat, how much hunger we have, how much satiety we will have, how much of gut motility we'll have, when are we going, how much is the nutrient going to be absorbed? These hormones dictate. So it's very important. But finally, all that I said, what if I told you all that is controlled by genes? Would you believe it? Well, let's see. There is enough evidence to show that some people eat less, some people eat more, right? I had a student who could eat 60 jalebis. I also had a friend who could eat no more than one egg in the morning. So genes control our appetite. Some people are genetically endowed, some people are genetically not endowed to eat more. Possible? Genes control our behavior. Half of these diseases, psychiatric diseases like anorexia nervosa, bulimia, binge eating, are now shown to have a genetic basis. Genes control our absorption. How much of nutrient is going to be absorbed? What is going to be our metabolic rate? That's controlled by genes. And if you look at this Stunkard study, this gentleman has done fabulous study, and he showed comparing twins and not twins living in the same environment, twins living in different environment, adopted children. He studied in these. And what did he show? I'm not going to tell you the methodology of the study, but the inference was genes account for 70% of the body weight, and environment contributes only 30%, which means much of what we say or do is not right, that it is our responsibility, it is in our hands. Many of these diseases of obesity are not in our hands, it's genetic. So the cause of obesity, one line, polygenic, complex, multifactorial. Okay, PCM, right? Polygenic, complex, multifactorial. At least one line you should add. What is the cause of obesity? It's polygenic, it's complex, and multifactorial. So treatment has to be individualized. You just cannot say if you eat better and you move more, you will lose weight. That concept is gone. It has to be individualized. Everybody will have a different reason for obesity. Having said that, the first line treatment will have to be common sense. If somebody has got a higher BMI, first thing is to put them on a low calorie diet, low calorie, high protein diet. The physical training has to come in. They have to spend more energy doing the muscle training. Muscle training increases the basal metabolic rate. And that is the reason why we can have a chronic weight loss. Psychotherapy, where whatever we say, now we've realized eating can be a psychological phenomenon. Mindless eating is one of the commonest cause of obesity. So mindful eating is something that psychologists can do. So these three are your mainstay. So your second line I want you to learn is the mainstay. I told you the definition. Then I told you about why Asians have higher, lower BMI. Then I told you the cause, and I'm telling you the first line treatment. Now I'm telling you, what is the success rate of your first line treatment? What is the success rate of doing medical treatment? This is a large study, although you don't need to remember the study, but I want you to know where all this comes from. So this is a large group of people, 76,000 obese men, and similar, 99,000 obese women, and they were followed for 9 years. They were all trying to lose weight in a developed country. They got a nutritionist, they got a physical trainer, they got a psychologist, and all of these people sought help for losing weight. They were followed up for 9 years, and what was seen was, despite their trying to make an effort to lose weight, how many lost weight in simple obesity? Simple obesity is class 1, BMI 30 to 35. 1 in 200 men, 1 in 124 women. In morbid obesity, 1 in 1,290 for men, 1 in 677. And in morbid obese, let's say you said, no, forget about coming to normal BMI. Even if the BMI is coming from 45 to 35, it will do. So that is like having a 5% or a little more than weight loss. So some surgeons, some researchers, they looked at this data and found out how many lost 5% body weight. Only 5%. If you're 100 kgs, how many lost 5 kgs? So they found 1 in 8 for men and 1 in 7 for men. So what it means is 10%. But if you are going to look for in morbid obesity, coming back to normal BMI, that's 0.1%. So what it means is 99.9% are not going to lose weight if they are morbidly obese. Yes, there is success rate, but it's too low. So bariatric surgery. Now, what does bariatric surgery, where do we use it? Number 1. So we use it in morbid obesity. I'll start from where I stopped. BMI more than 40. or these are NIH criteria, BMI more than 35 plus one comorbidity like diabetes or sleep apnea or chronic liver disease. BMI more than 30 in type 2 diabetes. Now we know that there are independent mechanisms why bariatric and metabolic surgery helps in diabetes, and therefore the BMI has been dropped. Even BMI more than 30 with diabetes, one can consider, not that one has to do, one can consider doing metabolic surgery. I have told you the indications here, and I'll tell you what guidelines came in 2022, how it was modified. But before that, let's talk about the contraindication. If I saw a 6-year-old child with morbid obesity, would I operate? Probably not. We will do diet, lifestyle, medical therapy, anti-obesity drugs, all that till the child reaches a skeletal age maturity, which is generally 14 to 16 years of age. So unless the child reaches skeletal maturity, we do not do bariatric surgery because it will stunt the growth because of the nutritional deficiencies it causes. That's number one. So young age can be a contraindication. Number two, elderly age group, nowadays not believed. Any age group can be taken up for bariatric and metabolic surgery if they are fit for general anesthesia. One has to be careful, however, about frailty index or sarcopenia. So I'll not go into detail. There's something called sarcopenia, which means you have a lot of fat and there's a lot less muscle in the body. So in elderly age group, it can happen. Third is psychiatric issues. If somebody's got severe depression, don't operate. If they have suicidal tendencies, don't operate. Bariatric surgery has been shown it can even aggravate the depression in these patients who have got endogenous depression. Exogenous means depression is due to obesity. Endogenous means the depression is due to internal biological mechanisms. So don't do surgery in those patients. Addiction. Somebody is consuming alcohol daily. They will first have to be de-addicted before taking up them for surgery, because that is going to be neutralizing our efforts to reduce their body weight. And finally, unfit for general anesthesia. A lot of patients will have cirrhosis decompensated, or they may have heart failure phenomena, especially left heart failures, not right heart failures. They can be managed. So some of these patients will have a severe COPD. So these patients may not be fit for GA, and therefore they cannot be taken. The recent guidelines, which came from ASMBS, the Americans as well as the Europeans in 2022, all the big names are here. I'm very proud that in this list of names, there is Kamal Mahavar, who's our 3 years junior to me in medical college. And his name is there on the paper because of the profound work that he has done in this area. So be proud of the fact that we have one person from the city of Calcutta. So what did they say? They said, based on the evidence, metabolic and bariatric surgery is now recommended for individual BMI more than 35, even if they do not have comorbidity. So there is a change now. It is getting relaxed. Even if there is no comorbidity at a BMI 35 and above, still can take this patient if their quality of life is affected. And look at the second statement. It should be considered even with BMI 30 to 35 in patients who are not losing weight and having metabolic syndrome. So quite a lot of relaxation in these guidelines, and they are not coming from just expert opinion. It is coming from evidence. Now the procedures. The procedures that we talk about are the gastric band, sleeve gastrectomy, Roux-en-Y gastric bypass, and now one anastomosis or mini gastric bypass. Now there are many more modifications, but for students, these 4 laparoscopic procedures are enough. Just remember these names and I'll show you the pictures. Endoscopically, we can put in a balloon nowadays, and we can also stitch the stomach from inside, called endoscopic sleeve gastroplasty. So these are obviously less efficacious, but sometimes it may be necessary in high-risk patients. Adjustable gastric band is something like this, a silicone band. It's not very popular these days. Why? Because 1/3 patients had complications over long term. Most important was the erosion. The band went into the stomach and they had to be removed. Also, there was a higher rate of weight regain and less efficacious. And every time you have to adjust. So the surgical team were always either loosening or tightening this band. Quite cumbersome. But this is how it looked like. You made a small window just below the G junction. A small fundus was entrapped between the silicone band, and this access port that you see, that was placed subcutaneously, And if you put in a syringe with saline and inflated it, that band would get tightened. So the patient wouldn't eat. And if they came and said, oh, no, it's too tight, I want to eat more, then you could put in the needle and then to withdraw the saline, and that would get relaxed. So that was the thing. Very simple, very neat, except the problem was efficacy was a problem, erosion was a problem, slippage was a problem, it would migrate, it would become tangential. So all that was a problem. Then came the sleeve gastric, Roux-en-Y gastric bypass, but I will go in the order of restriction to malabsorption. But in terms of historical chronology, Roux-en-Y gastric bypass came the first. That was the first surgery. But let's look at laparoscopic sleeve gastrectomy, which is the commonest surgery in the world now. Very simple. First, you dehease the omentum from the greater curvature, and then you chop off the stomach on the greater curvature side, leaving a banana-shaped stomach. It has to be away from the G junction. You should not have your staple line falling on the esophagus because there will be a leak. And in the bottom, antrum should be left about 3 to 5 centimeters. The more you excise the antrum, the more will be the gastroesophageal reflux. The Roux-en-Y gastric bypass, a little complex, so pay attention. Look at the normal stomach on the left. Look at the dotted lines on the left diagram. That represents, that is the pouch that we are creating at the top. We are going to fire staplers in that direction so that the stomach is now split into 5% and 95%. So that 5% is like 50 ml pouch. It's a 50 ml pouch. And look at the bottom, after the duodenum, jejunum, we will divide it at about 50 to 100 centimeters from the duodenojejunal flexure. And once that is done, look at the right side of the diagram now. That jejunum has been anastomosed with that pouch, right? And in a Roux-en-Y configuration, obviously the BP limb has to be joined with the common limb. So now we have 3 limbs. It's looking like a Y, right? So the Y, if you look at the pouch, from the pouch, the food is coming into that red line. That is first called the alimentary limb, okay? And from the stomach remnant, you see the green. Green is for green juices like bile. That is coming and joining with the BP limb at a point from which the common limb which is going down, that is called the common limb. So we have alimentary limb, we have got the BP limb, and we have got the common channel, a common limb. So the BP limb is about 50 to 100 centimeters, alimentary limb is about 100 to 150 centimeters, and common limb you don't have to measure because it is dependent on the length of the total small bowel. Now, going to where's mini? Sorry. Oh yeah. So that is the Roux-en-Y. The mini gastric bypass. How is it different? Because it is one anastomosis. If you see the Roux-en-Y, there are 2 anastomoses. One with the gastric pouch and the jejunum, and one here at the bottom, jejunum and the jejunum, right? Here, there's only one anastomosis. Now, the problem was in the Roux-en-Y, if you did not do a Roux-en-Y configuration, then there would be bile reflux. If the G junction is very close to the gastrojejunostomy, then there would be bile reflux. The bile is coming, it will go up. But if you do a loop configuration, but keep the gastrojejunostomy really low, then the bile will not go from the GJ into the esophagus, because this pouch, this gastric pouch, is now 20 to 25 centimeter long, right? Plus there's an intragastric pressure, so it is not going to have a bile reflux. So that is why it became simpler. You make a bigger pouch, you keep the gastrojejunostomy low, and this will be therefore only one anastomosis, because there is no question, there is no lower incidence of bile reflux into the esophagus. So this is the mini gastric bypass. But remember here, the BP limb in a Roux-en-Y gastric bypass was 50 to 100. That's what I told you. In this, it will be 150 to 200, which means there is more malabsorption. Whereas in Roux-en-Y, only 50 to 100 centimeter BP limb means very little malabsorption. It is mostly a restrictive procedure. Here, we are allowing a bigger pouch to allow patients to eat more, but the BP limb is 150 to 200 centimeters. Therefore, the malabsorption effect is pretty high. Balloon, this is how the balloon looks like, right? The endoscopic balloon. You put in a balloon, very simple. It's a 10-minute job. You bring the patient, I'll do the endoscopy, then I'll put in the balloon like a Seng-Stacken tube, inflate it, and it's done, right? Now, if I just categorize these two operations, the pictures that you saw initially, gastric band, sleeve and balloon are restrictive operations. They're only restricting your calorie intake, right? But if you look at the Roux-en-Y gastric bypass and mini gastric bypass, what are they doing? I am bypassing the biliopancreatic limb. Therefore, there is some amount of malabsorption also along with the restriction, right? Although current evidence does not allow us to categorize this, it is very important to understand in this manner for students. Now, why is sleeve gastrectomy the commonest procedure? Maybe a viva, maybe a short note. So the advantages over gastric bypass is, first of all, it is physiological. It's going in the same path. You're not distorting the GI continuity. The anatomy is preserved. One can do endoscopy because the anatomy is preserved and there is no bypass of the duodenum. There is less malabsorption of calcium and iron. Therefore, the iron deficiency, bone health is better preserved. Efficacy wise, there are some RCTs which show this more or less equivalent efficacy in terms of weight loss. But in terms of metabolic or diabetic resolution, a bypass would be preferred. Well, it's versatile. If you had to use it in a 10-year-old child, bariatric surgery, would you use a bypass? Well, most people will not. Most surgeons would not, but they would not hesitate to use a sleeve. Elderly patients where there's sarcopenia, okay, net less nutritional deficiencies with sleeve, so let's use sleeve. If somebody had a cirrhosis and or a kidney transplant, but they have a BMI of 50, the transplant surgeons are not taking this patient up. What surgery? Sleeve again, because in these patients, they don't want to cause any malabsorption of the immunosuppressant drugs that they will give after the surgery, after the transplant. And if you had a big hernia in the lower abdomen, you can't do a gastric bypass because the bowels are inside. And you don't want to disturb the infracolic compartment either. What surgery? Do a supracolic compartment surgery, which is a sleeve gastrectomy. Again, so very useful, very versatile. Inflammatory bowel disease. They tend to have resections in future and they can lead to short gut syndrome. So why even touch the short gut? Again, sleeve gastrectomy for inflammatory bowel disease patients with obesity. Patients with chronic medications. These are patients like rheumatoid arthritis and other stuff, and they are consuming medicines daily. These patients, again, you don't want the drug malabsorption. So, again, sleeve gastrectomy. Let's see the video of a sleeve gastrectomy so that we can have some change from only theory to practical. That is the stomach being held, and with a harmonic scalpel, we are entering into the lesser sac by that you can see the posterior wall of the stomach now. And we are dividing close to the greater curvature. The reason being, even if the stomach is burnt, it doesn't matter. That part of the stomach is going to go away. When we go up, you can see the spleen on the left side of the screen, and you keep going up. And once you reach right till the top, we would like to see the left cruise. And we always like to see the left cruise joining with the right cruise, because that means the dissection is coming. That is the phrenoesophageal ligament being divided. It is important to excise the entire fundus, and that is why this dissection is very important, because the fundus contains a hormone called ghrelin. And if the fundus is not divided completely, the ghrelin, that is your cruise. So if the ghrelin stays, and therefore the appetite will not be gone, so one may have inadequate weight loss. So that part of the operation is very important. Here again, we go to the antrum, which we will excise from 3 to 5. There's a bougie coming in, 38 French bougie going into the duodenum. And once that is done, we fire stapler. We want to keep a wide incisura and we want to make a straight line. That's two things important: wide incisura, straight line. So if you were ever asked in an exam, what are the precautions of sleeve gastrectomy? A, I would like to keep a wide incisura and I want to keep a straight staple line. Why? Because a wide incisura means that there will be no incisural stricture. Eating will be easy. Number two, it will not lead to a leak, which comes from the proximal staple line. And number two is the straight staple line means the eating will be better. A corkscrew staple line would mean the patient will not be able to eat comfortably. Now, just to show you how a gastric bypass is done. So I'm showing you mini gastric bypass because it's simple. You see here we are at the upper border of the stomach, not at the lower border. Last time in the sleep, you saw upper border. Here we are in the upper border. In the sleep, we were in the lower border. Once we make a window, we fire from the top. That's 45 stapler coming in. And once that is divided, we are going to create a long pouch. See how long this pouch is? It is not a small pouch, not like Roux-en-Y gastric bypass. So you will fire in gastric pouch maybe 2 staplers. Here, you will fire 5 to 6 staplers, which is why it is a very, very long pouch. The patients are able to eat, in fact, not too badly. They will have less, but it will be not as bad as a sleeve or a Roux-en-Y. And at the top, you can see we are not going close to the G junction at all, but rather wide, because this is not a restrictive surgery. This is largely a malabsorptive surgery. So there you have, we have divided. Now the stomach is being opened, right, at the bottom. Here we will do a gastrojejunostomy in a loop format, not a Roux-en-Y, loop, because this is a one anastomosis gastric bypass, because we made a long gastric pouch, because we're not scared of having a bile reflux, because this is too far from the G junction. Now at a spot between 150 to 200 centimeters, we have made an opening, and then we fire a stapler to do a gastrojejunostomy. Once we do a gastrojejunostomy, we start suturing. We start from 2 corners. This is a 2O PDS, which is used for all our GI surgery cases, whether it is colorectal, whether it is foregut, other surgeries, or bariatric. It's always 2O PDS round body. And you can see, again, in laparoscopy, you can emulate what you do in your open surgery, right? So this is, we came from the right side. Now I'm starting from the left side. So once I start from the left side, this 2O PDS. So again, we are going through and through. You may or may not like to leave the mucosa, but it's important to inspect them for a bleed. And finally, once this is done, we always check with a bougie whether there's a stricture at the GJ, and also whether we do a leak test to be sure that there is no leak of methylene blue dye. Now, outcomes of these surgeries, weight loss. This is our own study. We looked at close to 10,000 patients. And you can see that from multi-center study, BMI of 43 landed to BMI 32 median at 5 years. So, which is good. There is 11 BMI points down, mean level is down. Obviously, in this cohort, there will be some patients who would do very well, who will do badly, but the mean is 32. And if you look at between the 3 procedures, sleeve, Roux-en-Y, and one anastomosis gastric bypass, the one anastomosis gastric bypass, because it is malabsorptive, the BMI is lower, right? Sleeve is the least, then Roux-en-Y, then one anastomosis gastric bypass. So that is the efficacy on weight loss. And even this Taiwanese paper, for 15 years they saw, and they had the similar result. So such dramatic loss cannot be seen in any other mechanism or methodology apart from bariatric surgery. Patients with enormous body weight, with diabetes, with arthritis, with reflux disease, with NAFLD, all can be treated with one single shot surgery. And these surgeries will do well. Of course, we will look at the adverse outcomes also. How about diabetes remission? You must know at least this, that the bariatric surgery is not called bariatric and metabolic surgery for a reason. What is that single reason? The single reason is it is shown even if the patients do not have a higher BMI, at a low BMI, between 37 to 27 to 35, even if you do this surgery, gastric bypass, on a patient who's got diabetes but not a higher BMI, they will still have diabetes remission, even without significant weight loss. Why? Because the reason is that with this surgery, we are seeing that the gut hormones like GLP-1 increases. And you probably know that the GLP-1 analogs are the modern anti-diabetic medications. So GLP-1 works by sensitizing the insulin. It decreases gastric motility. It increases satiety. It alters the way glucose enters into the cells. So all this is leading to its anti-diabetic effect. So sleep and Roux-en-Y both lead to high postprandial GLP-1 as compared to patients who are diabetic. So this is diabetes remission, the reason behind it, and why bariatric surgery is called bariatric and metabolic surgery. If you look at this one trial, Stampede trial, randomized control trial, at 5 years, you find medical therapy success rate is 5% in achieving HbA1c less than 7. But a gastric bypass and sleeve, quarter patients, 1/4 of patients achieve a good HbA1c. This is the important trial that shows that the surgery works very well for patients with a BMI 27 to 40, not more than 40, 27 to 40. Influence on mortality and cardiovascular disease. Swedish obese subjects study. They looked at 2,000 controls and 2,000 patients who underwent bariatric surgery, followed them for 10 to 20 years. In these countries, follow-up is fantastic. What they showed, mortality rate in patients who underwent bariatric surgery is lower. They showed the incidence of diabetes, new diabetes in these bariatric patients are lower. They showed that the incidence of heart attacks in these patients are lower. Influence on chronic liver disease. This is a Splendor study coming from Cleveland Clinic. They looked at 650 patients underwent bariatric surgery and 508 who did not. For what disease? Obesity and NASH, non-alcoholic steatohepatitis. And how many patients went into liver failure with bariatric surgery? Only 5 out of 650. And how many who did not undergo? 40 out of 508. So if you do bariatric surgery, prevents going decompensation in NASH patients. So there is a lot of, so coming now to the last few slides to wrap my style up. You must remember that bariatric surgery and diet activity works in different methods. And this is very important for you to say that bariatric surgery works on not only by calorie restriction and malabsorption, but gut hormones, adipokines, neural mechanism, metabolism change in gut microbes, reducing chronic inflammation, and thereby resetting the hypothalamus set point. It is now seen as an epigenetic event, something that you switch off the bad genes. It's called epigenetic event. So bariatric surgery is an epigenetic event. Final, adverse outcomes. You must know side effects of bariatric surgery. Intraoperative, injuries, bleeding, sepsis. Early postoperative, leak. Yeah, there can be leaks. Again, bleed can happen in early postoperative period, port site infection, anesthesia-related complications, and also medical complications like, heart attacks, pulmonary embolism, lung pneumonias. These can happen. DVTs, these can happen. Long term, it is nutritional mainly and weight regain mainly. So nutritional issues, I will come, and weight regain, I will come. But how much is it? Mortality is now 0.04 to 0.3%. Remember, these are from centers who are doing it regularly. So our center would have probably this kind of mortality, but not the centers which start. There, the complication rate will be higher. Serious complications seen in 1 to 4%. And the incidence of myocardial infarction also mentioned here. But let me tell you just one slide for adverse outcomes. You can understand from the pictures with common sense that once you alter the anatomy with a bypass or with a sleeve gastrectomy, when we are making in a small tubular pouch, there will be increased gastric emptying. So the contact time of nutrients with the duodenum will be less even in sleeve. So it's like working like a functional gastric bypass. So when there is duodenum contact time is less in sleeve and not there in bypass, calcium and iron will not get absorbed. Therefore, iron deficiency, therefore calcium deficiency will happen in certain percentage of cases. So you have to give prophylactic multivitamin, multimineral. Okay. Even then there will be some amount of deficiency, which is 5 to 20%. Another thing will happen is protein deficiency. Remember, the amino acids are absorbed from proximal jejunum. So if the proximal jejunum is again bypassed, then there will be protein deficiency. So protein deficiency, iron deficiency, calcium deficiency. At least this much we should know. Remember, the antrum contains a Castle factor, the for B12 absorption. So vitamin B12 deficiency will also happen in both sleeve and bypass, but more in bypass. So that is about nutritional deficiency. Weight regain, yes. In a sleeve, you will get 25% weight regain. What is the definition of weight regain? If you gain 25% of the lost weight, it is weight regain, not 100%. If you gain 25% of lost weight, if you lost 40 kilos but gain more than 10, it's weight regain. That's the definition. With that, sleeve will have 25% incidence. Bypass will have incidence of 5 to 10% at 5 years. More you follow up, more this will happen because of chronic disease. Reflux seen in sleep, 2 to 5% because of the increased intragastric pressure. Strictures and hernias. So that is your adverse outcome. At least you should know nutrition deficiencies and weight regain. What is the take-home message? There's a misperception about obesity that it is because of lack of willpower that is leading to obesity. Not entirely correct, as I've shown you a lot of slides on that. It is better to say it is PCM, polygenic, complex, multifactorial disease. Therefore, the treatment of this disease, which is now called adiposity-based chronic disease, should be multidisciplinary. You should have a nutritionist, physical trainer, a obesity physician, endocrinologist, a surgeon, a plastic surgeon, a hepatologist, a gastroenterologist. Everybody has to see this patient. So there's a definite role of bariatric surgery in a specific subgroup. And I've told you the indications and contraindications, but you may have realized that the indications are expanding. And I would say if you had to choose one category of patient where it is very useful, it is in the morbidly obese patient with metabolic syndrome. There is absolutely no way that other treatment can give benefit as much as this. This could be a life-saving surgery for these patients. And I will leave you with this question. As a DNB surgery student, with this idea in mind that you can make such a marked improvement in another person's life with this surgery, would you want to become a bariatric surgeon? Thank you.
Thank you, Dr. Sarfaraz. It's a nice coverage in the whole topic. You see, if you consider the assessment of the patient, BMI is the first marker is mark the patient obese. So if you want to take up this patient for surgery, what should be the extent of workup? That means you're saying there may be a lot of disease, and then how far you keep on working up. Patient may not have any symptoms. He just came to you with obesity only. So how far you walk up to find out the end organ disease?
Yeah. So earlier it was very complex, and nowadays it has become very simple with the BOMSS guidelines and ASMPS guidelines. Earlier we used to think it is our job to hunt for all diseases. Look at what is the condition of the liver, what is the condition of the kidney, what is the condition of the heart, lung. Yes, we have to have a baseline, but earlier we even used to go to thinking about fibro scans and even urine albumin. Now we have realized almost all patients, like for example NAFLD, 90% of our patients have NAFLD. So what is the point in knowing that the patient has NAFLD? When we look at obese patients, they almost always have a NAFLD. So to keep the resources simple, what we nowadays do is we look at the BMI for sure, and we always get them evaluated for diseases that they present with. If they have a diabetes, definitely the endocrinologist will give us the idea, type 1, type 2. They will tell us whether it is an end-stage diabetes by measuring the C-peptide level. If they have sleep apnea, they will be evaluated by the ENT guys who will tell us this sleep apnea is severe or moderate or mild. They will look at the AHI, apnea hypopnea index, and other things. For example, we don't go into too much of detail. For example, many of these patients would have a lung disease, a restrictive lung disease. There's no point in going into detail. As it is, these things are going to get better. So much of this has become very streamlined. We evaluate things that they present for. From the lab tests point of view, again, we have to do ECG echo for the heart. We do a chest X-ray and a pulmonary function test for the lungs. We look at the ultrasound of the liver, but we don't do a fibro scan or liver biopsy routinely. Obviously, we are doing hematological tests to look at the renal function. We just do creatinine. We don't look at the urinary albumin anymore. We are looking at basic tests that you would do for any other surgeries. So that done, we also screen one more thing, which is nutritional. Many of these patients will come with iron deficiency, vitamin B12, vitamin D deficiency. So these are supplemented before the surgery. So this is the assessment for which has become very, very simple as compared to what we did in the past. Another thing is the endoscopy. It was controversial. In the West, endoscopy costs a lot. In India, it doesn't cost a lot. So in India, most centers would do an endoscopy before any bariatric surgery to pick up an ulcer, H. pylori, hiatus hernia, reflux esophagitis, and therefore that has become part and parcel. So some areas I've touched today. This is the assessment, and there is ASMBS protocol which is available for how you have to follow up these patients in the long term. But I'm not going to go into that since you asked me only about the assessment. Yeah.
In the post-op period, you said nutritional problems are more common. So how long will you continue the nutritional assessment in the post-op?
Yeah.
That means some tests to be done. What the duration? How long? Is lifelong or for some
Yeah.
duration?
So theoretically and from guidelines, it is lifelong. But the term has been changed now. It is called long-term follow-up. The reason is many of the patients after 5 to 10 years are not under follow-up. They are lost to follow. Many of them, especially in India. In the other countries, they have their number. People can reach out. In India, it's not possible to trace them. Sometimes they change their phone numbers. Even if we wanted to track them, we can't track them. So 5 to 10 years long-term surveillance possible in India, and that too for not all patients, for some patients. That's a practical problem. But what we have seen in sleeve gastrectomies, at least in about 2 3 years time, they keep on doing the tests. So the tests are done 3 months, 6 months, 1 year, and then annually thereafter. So annually they should be doing these nutritional testings. However, after 2 3 years, the yield rate of deficiencies becomes very low. So the yield rate is so low, the surgeons also lose interest, the patients also lose interest. But the gastric bypass, it's not true. In a gastric bypass, you keep on seeing iron deficiency even at 5 years. And these patients should be supplemented with iron, especially intravenous iron. So we've written a paper on why we think intravenous iron is better than oral iron, not only in bariatric cohort but also otherwise in the in society. But that I cannot explain in this small time. But IV iron is something that we need to give for these patients. Also, bone health is another issue that in elderly patients or perimenopausal women will be important. So there, stopping the supplements will not be good, and detecting that the bone health is deteriorating is very important. So I would say iron and bone health, these two things are something in gastric bypasses that should be looked at long term. In sleeve, one can relax, but in a gastric bypass, one cannot. One has to keep on monitoring these patients. But unfortunately, 5 to 10 years down the line, it's very difficult to track patients.
And in this context, I like to tell you, Government of India is coming up with a unique health ID in the form of
Yeah.
Aadhaar. So anybody having a health issue come to any doctor, he will have a unique health ID. And that number has to be there in all the follow. But it's not implemented. There is a plan and some work is on. It will be nice. Then
That would
you
be
can
nice.
track anybody. Like Aadhaar, now Aadhaar is one, everybody is tracked.
Yeah,
So there is a
true.
unique health ID. It will be good that you can put his number and can find whether he has gone to some other doctor or not, or
Yeah.
his health status.
So,
Okay,
this
thank
is
you very
why.
much. I bothered you one day
No,
earlier
no,
because the fellow was supposed to present, but he became sick. So I thought
no,
we
no.
can continue the class.
I'm glad I could do it
Thank
today.
you. Thank you very much.